Hi, Nicole. I haven't seen you in a long time.
Good morning. I was so excited to be here and follow quite closely. So just wanted to say hi, Michelle. I'm glad to see you.
Yeah, it's great to see you. Hi, Maya. Good morning.
Good morning, everyone.
Morning, Sally. All right. So now, is it a good time for me to get things rolling, or do we still have people hopping in?
We are expecting a few more people, but I don't think there's a problem if you just start sharing some of the remarks now.
Okay, wonderful. There's a little housekeeping that I'll run through to get us rolling anyway before we get into the good stuff of the presentation. So first of all, a welcome to everybody. It's lovely to see some familiar faces, and there's some new names on the screen that I might not have met before. My name is Michelle Phoenix. I'm a core member of the McMaster Equity-Based Co-Creation Group, and I'm helping to facilitate today's session. By means of orientation, you're all welcome here with either cameras on or cameras off, whatever you feel most comfortable with. We are recording the session, and you might have seen a pop-up on Zoom about that. We typically post those recordings on our Co-Design Hub website, and they're also made available to the presenters if they'd like to share within their networks. So if you're not comfortable with your face being on screen, just feel free to turn your camera off, especially if you're making a comment. There will be some opportunities for dialogue throughout our session. The presenters have asked if you have any questions or comments as they're going through the more formal part of the presentation. You're welcome to put them into the chat, but we'll just hold them until the Q&A time. And we have tried to save at least 25 minutes towards the end for open dialogue about this topic. So we really hope to hear your thoughts and your connected ideas. So that's about the chat. If you want to share a verbal comment, especially during the Q&A time, if you don't mind raising your virtual hand, and to be able to do that, there is a raise hand icon down at the bottom of the screen if you hover over the bottom line. And if you click that, you can probably see mine go up. It just means that you'll populate to the top of the screen, and that way we'll see that you have something to say. If you can't figure it out and just want to unmute and talk, we're really a happy, flexible crew here, so feel free to be able to do that. Um, well, there is, if anyone doesn't want their name showing, you have the option to participate anonymously. So you can rename yourself in the chat if you would like to be able to not have your name showing on the screen. That said, we really like knowing a little bit about everybody who's here in the room. So if you don't mind putting in the chat, maybe just a little bit about where you're joining from, or sort of what brings you to this topic, or maybe the related work that you do. I think it would be helpful for us to know who's been joining kind of our collective learning space, but also maybe helpful to the presenters to know a little bit about who they are presenting to. So please feel free to start putting your own information into the chat. You might know that the equity-based co-creation is an interdisciplinary group of trainees and researchers and people with lived and living experience. So we tend to have quite diverse audiences joining this. And I think today, especially people from all over the world as our presenters and maybe as our audience as well. So we'd really enjoy meeting you. Thanks, Rose, and good morning. So I'll continue on as people are introducing themselves, just to give as much time to the presentation team as I can. I'll be doing a brief land acknowledgement, and then the presenters are going to introduce themselves. Just so we all know we're in the right space, the topic today is moving from Baby Ubuntu to Encompass, and those are both program names. So if those don't mean a lot to you on their own, just hang on for 2 seconds and the team's going to tell you all about their programs and introduce themselves. So We'd like to acknowledge that McMaster University recognizes and acknowledges that it's located on the traditional territories of the Mississauga and the Haudenosaunee Nations and within the lands protected by the Dish with One Spoon Wampum Agreement. And that is a land acknowledgement you might have heard before. What I try to do when I do land acknowledgements in different spaces is to personalize them for that particular content and context. So today I had the opportunity to reflect on the very recent presentation by one of our equity-based co-creation faculty members, Lori Davis Hill, who gave a fabulous presentation about her identity as an Indigenous person and her connection with language and community and what that means in terms of healing, but also identity. And today, as we hear about these really culturally grounded programs that enable children and families and communities to connect with one another and learn from one another, it really reminded me of her words and her teachings about how important language is in supporting these identities and connections with the people around us. So I'm going to be thinking about that as I listen to your presentation today. Sinette, are we ready to roll into the presenter slides now?
Yes, we are. Please, Kristen, feel free to start sharing. Thank you.
Can everyone see my screen okay?
Yes.
Brilliant. Thank you so much, Michelle, for welcoming us today. We are so looking forward to being here, talking about the two programs, Baby Ubuntu and Encompass. And I think they are both really relevant because they both have a lot of co-design work, and in the case of Encompass, co-adaptation work. And both programs are also co-delivered by people with lived experience. So really looking forward to sharing a little bit more about it. But for now, let's introduce ourselves and who is talking today. So I'll go first. I'm Kirsten. I'm an occupational therapist and PhD fellow. I am from South Africa, but I've been in the UK for 8 years. And so I sort of bring that background of living and working in both South Africa and the UK. Can I ask Rachel to introduce yourself?
Yes, good morning or good afternoon. My name is Rachel Lassman. I'm an occupational therapist, also by background. I have been living and working in Uganda for the last 13 years, and I'm currently a research fellow at the London School of Hygiene and Tropical Medicine. And I've worked with the Baby Ubuntu programme since its design and pilot, and I'm currently the programme's global program coordinator and support partners with the mentorship and training and implementation of the program. I'm really happy to be here today, excited.
Thanks, Rachel. Carol, are you okay to introduce yourself?
Yeah, I'm fine. Thanks, Kirsten. Hello, everyone. I'm Karina Nyunja, a clinician by background and also a research assistant and a PhD student at the London School of Hygiene and Tropical Medicine. I've supported the Baby Ubuntu program since 2016, and I am the male coordinator for the Baby Ubuntu program. Happy to be here.
Thanks, Carol. Alia, are you okay to introduce yourself?
Hello, everyone. Yeah, my name is Alia, and I'm a parent with lived experience. I'm also a research partner in Encompass study based in UK.
Keely.
Hi everyone, I am Keely. I am also parent, same as Alia, that helped with the Encompass manual and also a parent facilitator for the Encompass.
Thank you, Keely. So yeah, we've got a team from all around the world today and presenting to you in Canada. So it's very exciting to all be able to connect. But let me quickly go through our session outline for today. So we're going to start with Rachel and Carol talking about Baby Ubuntu, how it was co-designed, how it's been implemented, and just the growth that they've had as well. And then we'll come to me where I'll talk about Encompass and why and how we adapted Baby Ubuntu for the UK context, and we developed Encompass. And then most importantly, we've got hearing from Ali and Keely, our Encompass parent partners, and they'll be sharing their experience of how they were involved in the adaptation of the program, but also delivering the program. And then I will end with a few points around challenges and successes in relation to co-design. So I think I'm going to hand over to Rachel first. Is that right? And you can just let me know if you need me
Yes,
to.
that is right.
Cool.
Okay, so I'm going to be sharing uh, the development and telling you what Baby Ubuntu is. So Baby Ubuntu is an early care and support program for young children with developmental disabilities, and it was developed in Uganda. Next slide, please, Kirsten. So our vision is until every child with a disability is included. Next slide. So as many of you are aware, there are currently 53 million children globally under 5 years old living with developmental disabilities. The majority of these children are living in low and middle income settings with limited access to support or resources. And I think we all recognise that these children have complex needs and their stigma and discrimination is widespread in most countries. And there is need both for support for the children and for the parents. So in response to that need, these are some of the founding reasons why Baby Ubuntu came into being. Next slide, please. So Baby Ubuntu sits under the Ubuntu Hub with its sister programs. So the Ubuntu Hub is a non-profit research and educational hub that's part of the London School. Ubuntu is a Zulu term that means humanity towards others, or I am because we are. And it's a term that there's a word for it within Uganda, within Rwanda, within Malawi. It sort of travels up through sort of southern and central Africa, with this idea that we are because of how we exist with others and how we treat others. So all three programs aim to improve the lives of children with developmental disabilities and their families. So we've got the Ubuntu program, which was originally called Getting to Know Cerebral Palsy, which is for children from 2 to sort of teen years. We have Baby Ubuntu, which focuses on our youngest children, so 0 to roughly 3 years old. And then Juntos, which was developed in Latin America for children with congenital Zika syndrome. And all of these programs are co-designed and centre on the lived experience of the child and the caregiver. And we want those programs to be owned by the communities in which they are run. Okay, so we have a shared learning platform. We have an online community of practice. We have webinars every 2 months, and a WhatsApp group for implementation partners. And shared learning is one of the things that I'm really passionate about across our implementation partners and other people doing similar work. Next slide. So what is Baby Ubuntu? So it's a participatory peer support group for young children. It was co-designed by families in Uganda. And as Kirsten mentioned, the groups are co-facilitated with a healthcare worker or a community health worker and an expert parent, so a parent of a child with a disability. And that partnership is equal. Every session is participatory. It has practical skills that are practiced together through demonstrations, trying it out, reflection, and supporting each other. And the caregivers sharing their stories and experiences is a central part of the group and of them learning together. And we feel very strongly about the participatory approach and our groups not being a health education lecture, because we believe this creates meaningful participation and supports empowerment for caregivers. Next slide, please. So Baby Ubuntu is 11 modules currently, although we keep adding. So we cover, I'm going to talk about what we cover in the next slide actually, because there's better pictures. But the goals of the programme are to promote inclusion and participation of children within their families and communities, to maximise development, health, well-being and quality of life, to promote empowerment of caregivers through the sharing of information, experiences and peer support, and through that sharing of stories to address issues around stigma and to promote the rights, human rights of children with disabilities. Next slide. So our content, as you can see from the pictures, the groups are participatory. When we cover sort of what is disability, what is development, we cover positioning. When we are doing positioning, we are working with our children. So the little boy in the middle lying on his tummy, we are practicing lying on the tummy in the session. We cover feedings. We've got the father feeding his child with a cutaway cup. We cover play and communication, as is clear in various of those pictures. And we also have a module called Togetherness and Belonging, which is about stigma, and modules about our community. And the final module looks at sort of the next steps and how the groups want to continue to meet and support each other after the groups. Next slide. So the development, the co-design. So we started with Getting to Know Cerebral Palsy, which was written for much older children. And we had a cohort of children born with neonatal encephalopathy in Uganda that had been followed from birth, assessed for neurodevelopmental outcomes at a year and again at 2.5. And at 2.5, the caregivers' experiences were really negative. They were being excluded by their communities. A lot of the fathers had left. We'd referred them for services at a national hospital level, but a lot of them hadn't been able to maintain attending the services, and the parents were really struggling. So that took us to take Getting to Know Cerebral Palsy and look at developing something that was for this group of children and this age group. So we worked with an expert advisory panel. I think you can keep clicking round so it fills and it was rewritten for this young age group, particularly around the feeding was and positioning was really important. We then ran the groups in the local language with expert mothers. At the end of each group, we obtained feedback from our expert mothers and from the mothers who'd attended. We then modified the content of the programme. We then reran the groups. We did home visits. And we went through this cycle 5 times. So we ran 5 sets of groups and rewrote the programme 5 times to get to the programme that we've got today. And all of that was based on caregiver feedback, supported by this global panel of experts. Okay, next slide, please. So currently we have the manual, which is available online, free to download. We have access to our shared learning platforms and resources, and then we provide training, different trainings to meet partners' needs. So we have sort of trainings around sort of implementation and how to get started. We have a 5-day facilitators training, which is run by a master trainer and has ongoing mentorship to enhance fidelity of the programme. And we have a 3-day master trainer training, which enables people to run their own facilitators training. So I am really passionate about all the organisations we work with in all the countries we work in to have their own master trainers so that they can own and grow the programme as they see fit. And we are also currently developing a tablet application to support the manual, which has more videos and visual resources and gives a more dynamic, easy to access and understand content. Next slide, please. Okay, I'm going to hand over to Carol, who is going to take us through our impact, our reach and coverage, and our evidence base.
Thank you, Rachel. Just to tell you that this program has gone through rigorous research, and we've conducted a feasibility trial, and the program was found to be low cost and feasible and acceptable to the communities that was run. Then we've also conducted a mixed methods evaluation. This was done in Uganda, and it showed a 15 to 25% improvement in the family impact quality of life. And currently we are conducting a cluster randomized trial in Rwanda, and we've so far recruited 1,472 children to the trial. And we shall be conducting also an economic evaluation as part of the trial. In terms of reach, we have 27 implementation partners across 13 countries currently, but we're welcoming all who are happy to take on the program. Currently, we have 110 baby Ubuntu master trainers, and we have, as Rachel mentioned, the shared platform has 576 participants, and we've reached 2,844, and we're still aiming for more, and we've trained 516 facilitators across. Next slide, please. These are some of the quotes that we've got, the quotes from the families that we've worked with during the different researches that we've conducted. The first quote is, "The training helped me to understand the thoughts of abandoning my child. Cease and her life improved. I no longer feel sad, stressed, and sad. The group has empowered me in a way that I am confident to stand up for my son. Meeting other mothers has taught us a lot. Fellow mothers give us hope that our children will improve, and this kept us strong. Like, since we ran all these groups, all these sessions in groups, at least we found that there's reduced stigma, as you can see in the quotes shared here. Next slide, please. Another quote here goes, "We were taught on how to carry our children as we do our normal work. This helped us to continue our work as we took care of our children, but also helped us to involve our children in daily activities. We used to think we could not work when you have such a child. Commonly, what we find is that the families tend to desert their children into the houses or under the beds, commonly in Uganda. But after attending the group, they embrace that these children can be able to do a certain activity, and also they involve them as they do their work." Next slide, please. For shared learning, these are some of the things we've found to be very important in terms of scale up. There is high demand for the program in the community because currently there is nothing out there for families in their niches. Then integration of the program. So we're working so hard to integrate this program, the Baby Ubuntu, into community health systems so that we support accessibility and therefore it will be acceptable to the community. Then we are trying to also engage all the local leaders, the health workers, and also the community at large in order to reduce things like superstitions, self-stigma, and also promote inclusion for these families. We have a quote here, when there is community support, then the Baby Ubuntu program has lasting impacts on the lives of the children and society. This was a quote from one of our parents. And as we know, engaging fathers is very critical for mothers accessing care and support. In our setting, commonly, if a father says the child and the mother shouldn't attend a session, they will not show up. But when we engage the fathers into discussions and tell them how this program is important for their children, the mothers will be allowed to come. And sometimes also you'll find the fathers joining the mothers to actually learn together. Then poverty, financial impacts of the child disability are key barriers to access and improved quality of life. In terms of this, we've actually developed the livelihood module. The livelihood module, like Rachel mentioned, we keep adding more modules to the program so that since most people end up losing their jobs, so we, at least with the livelihood model, they are able to actually self-sustain them and try to fight poverty as they care for their children. Then important factors to consider: capacity of the healthcare systems. Use of expert parent supports the task shifting for overstretched health systems. And then fidelity, robust training and mentorship structures, and adaptability. The programs are adaptable to meet the local context and needs of the families. Next slide, please. In conclusion, the Baby Ubuntu is an innovative and low-cost intervention, which has been found to be feasible, acceptable to the families. And through the researches, such as the mixed method evaluations, we've provided a strong qualitative evidence of impact on family knowledge, skills, attitudes, and quality of life. Then partnership between expert parents and healthcare workers, it has been shown to support the transformation of community dynamics. Thank you very much, everyone.
Yeah. Thank you, Carol. Thank you, Rachel, for sharing about Baby Ubuntu. Yeah, it's been brilliant to even just see it grow in the last few years that I've sort of known you all. So thank you very much. I'm going to speak a little bit about Encompass now, which is a much smaller scale bit of research compared to all of the bits that Baby Ubuntu have done. But Encompass is my PhD basically, and I'm going to tell you why we chose Baby Ubuntu in the UK to try and how we adapted it, and also speak a little bit about our small pilot and feasibility study. So let me tell you about where we are first. So we're in East London in two boroughs called Newham and Tower Hamlets. And in these boroughs, we've got a high diversity of languages, cultures, and ethnicities. We also have high levels of poverty and inequality and low levels of health literacy. And that is sort of, we see that in clinics, maybe parents not fully understanding different diagnoses or knowing where to look for the information or where to look for help, and knowing when to ask for help as well. We also are operating in a government-funded National Health Service, which is underfunded and also facing a workforce crisis. So I think there is an appetite for innovation too in the settings that we're in. So how it came about, the adaptation, we followed the ADAPT guidance by Moore and colleagues, and that was published in 2021. And it really starts with establishing the need in the local community. And this all began with a pediatrician and professor, Michelle Hayes, who's now my supervisor. And she was working in Newham, and she was seeing children diagnosed with cerebral palsy or similar conditions, and felt like she was just sending the families off without any support after the diagnosis, and really felt like she wanted to do more and give more to the families in terms of support, information, and also connecting them up with other families. So her team conducted a qualitative study which looked at the needs and priorities of the caregivers and the healthcare professionals in the community. But they also showed them the Ubuntu program and asked them what they thought about it, whether they thought it might be feasible in that community, what they would change about it, and basically whether they think it might work there. We've published the first part of this qualitative study, and we published a paper about the needs and priorities of those who care for children with complex neurodisability. And the paper is titled There Was Nothing, Just Absolute Darkness. And that was a quote from a parent that we interviewed who felt like when her child was given the diagnosis, she wasn't given anything else and it was just darkness. And I think that just really speaks to the absolute need for support, particularly around that time of diagnosis, but also other key transition points in their child's life and their journey. Once we had all of this information from the qualitative study, we formed an adaptation team. And this team consists of the original creators of Baby Ubuntu. So you can see Rachel's on that team. And also expert parents, people with lived experience, very importantly, and people with expertise in different methodologies, but also the local context and the population that we were working with. And so we had these adaptation meetings where we brought findings from the qualitative study in terms of what people thought about what they should change or whether they thought that the Baby Ubuntu program would work. And we started to make some key decisions around delivery and the content of the program. We also then had co-design workshops, and these were purely with parents with lived experience. So we would bring the manual, but also decisions about how we would deliver the program and which modules to do to these workshops. And parent would discuss, bring their own lived experience, and we would make decisions. And then that ended up in drafting a new manual. So very briefly, the delivery plan. I realized, Keely, I'm sorry, there's so many pictures of you here. So the delivery plan was for parents of children with complex neurodisability under the age of 5 years. They were asked to attend 10 modules, and each session was 2 hours long. And the modules were facilitated by a parent with lived experience and an OT or a physio. And then as part of the pilot and feasibility study, we looked at recruitment and retention rates, and then also piloted some outcome measure questionnaires. And I also conducted semi-structured interviews with all the participants and the facilitators as well. So we ended up with a 10-module program, which is very similar to Baby Ubuntu. We just combined 1 or 2 modules, and we added a module called Going to School because parents wanted more information about the schooling system and how that all worked, because it is a bit of a minefield. But the goals of the program are the same. They're to improve the skills, knowledge, and confidence of the parents and caregivers, and also provide an opportunity to meet others. The core aspects also remained unchanged. So it was very important that it was still a participatory approach. It wasn't just a lecturing workshop, as Rachel mentioned, where parents are just given information. It's very much about sharing each other's experiences and learning from each other. And it was also important to have an expert parent facilitator. I adapted the Baby Ubuntu training for the UK. It was also very similar. We just adapted some of the activities to make them more relevant. And both the healthcare professionals and the caregivers were trained together to ensure power sharing. And I think it was a learning curve for everyone to see each other as partners in facilitating rather and sort of overcoming that parent and therapist relationship, which was usually there, I think, in terms of the power dynamics. Expert caregivers were paid for their time always, and then training focused on adult learning, participatory approaches, and we also practiced different parts of the manual. I've just popped in a few lessons learned through the co-adaptation process here. And the first thing to know, I think, note is that the experience of raising a disabled child is similar across vastly different contexts. And I know that Keely and Alia will speak a little bit about that too, that there are so many similarities. The modules were also relevant to the UK context, and parents appreciated the structure. They appreciated having a topic to come to and talk about, but also having the flexibility just to connect and talk about other things too. The expert parent facilitator is really key for success. And for parents to be able to see someone further along in their journey really gave them a lot of hope and eased anxiety around the future. Co-design takes time and can't be rushed. And this links to the final point where I said, don't try and make a perfect manual first time. I know Rachel mentioned that they went through five loops of going through the manual and testing it out. They gave me that advice when we started, and therefore we didn't hold the manual too tightly. Even through the training we were editing, as well as through when we actually delivered it, we were thinking about what could be changed. And refreshments and a suitable space are important for co-design workshops. So some very brief preliminary findings from a small pilot and feasibility study. Is it feasible? So we managed to recruit 9 parents out of 35 who were approached. And I think recruitment is the trickiest part because these parents have a lot of health appointments for their child. They have a high level of caregiving responsibilities. And I think it is tricky for them to commit to a program like this. And I think that might be a difference between the UK and Uganda contexts. However, of the parents who did sign up to attend the groups, most of them attended 8 or more sessions out of 10. So we had a high attendance rate and a high retention rate, even if recruitment was tricky in the beginning. Groups were run with high fidelity. We adapted a fidelity checklist based on the Baby Ubuntu one, And I was in every group doing the fertility checklists alongside a second reviewer who came to a proportion of the groups. And we had a return rate of the questionnaires of 86%. So we did all the outcome measures at baseline, at endline, and at 3 months follow-up. And we saw some improvements relating to empowerment and well-being. So is it acceptable? And Keely and Alia will speak a bit more about the community of support that was built. There was one group where both Keely and Alia brought their children to the group. So their children are both teenagers or young adults. This wasn't planned, it wasn't part of the program, but it was mentioned by every single parent that this was a highlight of the program. To see someone further along in their journey with their child was very important for them and gave them a lot of hope. Parents became gentler on themselves, they learned where to ask for help, and they worried less about the future. As I mentioned, these are very preliminary findings, but these are the scales that we tried out in the pilot study. So the parent-patient activation measure probably relates to that health literacy aspect. So it's a parent's understanding of their child's diagnosis, their medication, who to ask for help, when to ask for help. So that went up along with the Warwick Edinburgh Mental Wellbeing Scale. I would say that the Family Empowerment Scale, parents found the most tricky. It was very long, and it also had some words which I think were more Americanized and difficult to understand. We looked at the quality of life as well as a power ladder question, which was a very open-ended question that said, imagine you are on a ladder, the lowest rung is a 1, the highest rung is a 9, where you have all the power in the world at a 9 and no power at all at a 1. What number are you on the ladder? It was a very simple question relating to empowerment, and we saw improvements in that as well. And here are just some quotes that show the importance of having the expert parent being the deliverer of the program too. And as I mentioned, just seeing someone further along in their journey, just knowing what they're going through was very important. But I'll let you hear from Keely and Alia more about that. I also just wanted to include why Encompass, the word Encompass was chosen. We've heard about the lovely word Ubuntu, but Encompass has got quite a nurturing feeling to it. It means to include comprehensively, to hold and to surround, but it's also got the word compass in it. And that sort of helps us think about navigation and helping parents to navigate their journeys. So I just wanted to quickly put the slide up to mention all the people involved and all of the funders involved as well. And the fact that we also have a website here where we are putting up all our publications and any news and updates there. So if you'd like to have a look. But yeah, I think I'd like to hand over to Ali and Keely now to speak a little bit about their experience. And I'm really looking forward to hearing from you both. And I can't remember who goes first. Oh yeah, there we are. I'm going to hand over to you to introduce yourselves.
Hello, everyone. My name is Alia, and my daughter Khadija. You can see her picture there. So I'll just tell you briefly what Khadija's diagnosis is. I'm going to try to pronounce it. It's a metabolic condition called arginic succinic aciduria. It's short for ASA. It's a metabolic condition, and her second diagnosis is it's an incurable epilepsy. She has LGS. Khadija is a very happy child, and she loves when somebody engages with her, plays with her, just sings to her favorite nursery song. It's just, she brings so much. Just looking at her, she just has this smile on her face all the time, and yeah, she's just a joy to be around. And I will pass it on to Keely.
Thank you, Alia. Yeah, my name's Keely. I'm parent to Jack. He's 16 years old. He has cerebral palsy, epilepsy, and a few other bits and pieces to go along with it. Jack is a very cheeky, happy boy, as you can see by his picture. Absolutely loves British soap operas. I don't know if any of you have ever heard of EastEnders, but that is Jack's ultimate favourite thing to watch and talks about it all day long. So yeah, that's me and Jack. I'm just going to go on to talk about the outline for our session. We're going to be talking about me and Alia. So just going to start off with our involvement in the adaptation. Then we're going to go on to do development of the new manual, as Kirsten's mentioned as well. And then our perspectives of being parent facilitators and putting on the actual sessions and the manual. And then what we do or what we have done after the program. Once the program's finished, the next step after that, where we go from there. So just going to pass you back to Alia now.
So I'm just going to talk about the adaptation of the program, the differences and similarities. So day-to-day life can be quite different, such as the way we carry our children, feed them, and daily activities such as like teen foods, and in other countries they might feed them, make food, cook food for the children, and where the program is delivered sometimes outside in Uganda, but in the UK we did it inside given British weather. In Uganda, health professionals are seen as the experts rather than the caregivers. So in the UK, parents are with the lived experience are the expert. And the similarities, beliefs about disability and not understanding what causes it. I think there's a lot of, in some cultures, there are taboo or, stigma in different cultures. Parents, caregivers feeling isolated and alone. I think that's one of the biggest, a lot of parents go through that, feeling isolated and alone, nobody understanding what you're going through, not connecting with a lot of people. And fathers are often not involved in the care of their child. That's another one of the biggest, fathers not being involved as well.
I'm just going to talk about changing the manual. So obviously a lot of things are a bit different from Baby Ubuntu. So it's just sort of things like changing the wording. We changed certain things that were, I think in the other manual it was a bit more direct. So we just changed it so it was a bit less direct and about sensitive topics, like regarding sort of certain things that were said about the children and how parents reacted to it, and also changing pictures so it was more relevant for the families in East London. A lot of the pictures from Uganda were sort of, as Ali was saying, was based with the children outside and doing different activities that weren't relevant for us in East London. Changing the activities as well, such things like food, the toys, equipment, carrying methods. We carry our children a lot different to how the mothers do in Uganda, and we have a lot more equipment. I think we've got a lot more access to different types of equipment than the parents do in Uganda. And also we combined some of the modules. Some of the modules were quite similar. So learning to move and positioning and carrying were quite similar. So we decided to sort of combine them into one session, which seemed to work quite well.
Perspective on the expert parents facilitator role. Nervous. I was very nervous to be seen as the expert, used to being advised by the professionals. So that was it was nerve-wracking working along with the professional. Ended up changing the relationship with the health professional, became partners. So I felt more comfortable working with the professional I was delivering the workshop with. So that helped. Found it empowering to share personal lived experience. Enjoyed bringing my child into the group, made it real. Definitely I would say it was the highlight as well for me to bring Khadija in to one of the session. it's just, you know, a lot of parents gave feedback, and I think that makes it real. Like I think Kirsten was saying, that it just is for parents to see myself and Keely, we have come a long way. And yeah, so that was the highlight, I would say. Sometimes found the manual hard to too much wording information. Definitely for me, you know, I like to just keep it simple. And found it useful to have a meeting before each group to divide up the activities. Definitely, for me, I like to be prepared before running workshops, so I know what I'm doing. It's just being organized, really. Yeah.
This is my perspective now of being an expert parent facilitator. I was really excited to be working alongside the health professional, as like the OTs and physios that I've worked with my son Jack. I've always seen it as a joint effort in doing like helping Jack to get to where he needs to get to. So I was quite excited to be working alongside them. And also I found it empowering to empower others, to give them a heads up about the journey ahead, because it can be a bumpy road. So it's just nice for me to be able to sort of speak to other parents and just give them a little heads up with certain things that they're going to come across, or more than likely to come across with their journey. So it's not such a shock, and they've got a bit of an idea of what's to come. And also just helping others to carry the load, sharing things makes you feel less alone. It's nice just to have someone you can chat to that has a bit of understanding of where you're coming from, and yeah, and what things you're going through as well. I found the manual really helpful to guide the conversation. Sometimes it did sort of veer off to the actual topic we was doing, but it was good to have the manual there to bring it back to what we was talking about. The structure of the manual I found really helpful as well. The icebreakers at the beginning, I think, just made everyone feel really comfortable. And after sort of the first couple of weeks, I think everyone looked forward to doing the icebreaker. It's a bit more of a fun, sort of interactive sort of part of the session. And also at the end, we always done like a bit of reflection at the end, just asking everyone how they felt the session went, if there was anything they wanted to discuss or bring up, or how it made them feel. I think that was really helpful as well, just to get that sort of out in the open. And if there was any sort of like sadness or happiness, it was just nice to share with everybody. I found it quite tricky sometimes juggling the different needs of some of the parents, because we had a deaf parent, and we had an interpreter, which I've never come across before. So I found that quite sort of tricky and nerve-wracking, but it worked really well in the end. So yeah, thank you.
Yeah, so I'm just going to talk about the beyond the program. Doing the Encompass parent facilitator, talking about my lived experience, it has opened a lot of opportunities for me. It pushed me to share my voice and experience with the world. I think words and voice is very powerful. And when it comes me speaking about my lived experience, I love speaking about and empowering other parents. Feeling that lived experience very powerful, which I've just mentioned. Haven't learned this by studying, but through real life experience. It's lived experience. It's my lived experience. We all parents have their own story to tell, and we all have our unique story. I have mine, and that's why I have started a podcast. And it's just, yeah, it's been a very emotional journey. Never thought I would have my own podcast, and then I start doing a it's called Special Educational Needs and Disabilities Community. I started this after Encompass. So Encompass parents, other regional parents of the Encompass, and we wanted to grow this group, and we came up with Send Community. So we have like 25 parents in WhatsApp group, and every second and the fourth week of the month we have coffee morning. Parents come and just connect with other parents, have coffee and just chat. And it's also all about that, parents connecting with other parents, and you have parents coming for advice, and through lived experience we share that, supporting other parents who are going through difficult process. I found that very challenging because it brings a lot of my memories back, or those difficult process that I had to go through. But I went through it and I got through the other side, and that's why I like to support parents, telling them that you'll get through this. And yeah, so that's my Beyond the Program. Thank you.
Sorry, this is my Beyond the Program. I've met up with a few of the original Encompass parents to have a coffee and walk and just have a chat of how sort of everyone's doing. We've also got a WhatsApp group that was set up after the Encompass program so we can all keep in touch with each other. And then Ali has obviously brought it to the Send community, which is really, really good because we've brought a lot more people in with that. I feel like I've made lifelong friends with the Encompass program. Some of these parents have, really got along with well, and it's just really nice. They've helped me just as much as I've helped them as well, because it's given me confidence as a parent to sort of just not certain appointments, just feel like you don't have to go to each and every one, just to say sometimes, look, I can't do it all. It's okay. That is okay to not be able to do it all. I'm also going to be on Alia's podcast as well, sharing my lived experience soon, so really excited about that. And I think the best thing I've got out of this is just sort of realizing that I can be more than just mum, more than just a caregiver. It's possible to go and get a part-time job, which I've done now, to get more care for my son, so I'm able to be mum and not just be sort of Jack's carer. I think that's probably the best thing I've got out of this, which is really, really good. Thank you.
Thank you so much, Keely and Alia, for sharing. Yeah, it's been incredible watching your journey from meeting you a few years ago and seeing how your confidence has grown, and where you've gone beyond the program as well. So I was just sitting there smiling from ear to ear, listening to you both speak. So thank you so much. I've got a few reflections on co-creation that we put together that relate to some of the challenges and successes. In terms of challenges, I've said this before, it takes time and can't be rushed. Everything took longer than expected throughout the adaptation and the co-design process. And that we all work and learn together in different ways. So some might prefer a lot of text and reading and editing and writing, and others would prefer to just to speak about their experience. Some prefer, they need visuals to be able to do the co-design process, and some prefer to work at their computer and add comments. So I think that was also just juggling everyone's different ways of working. Something I found in the UK, I'm not sure so much in Uganda, is that, as I mentioned before, parents with children with complex neurodisability are very busy. They have a lot of different appointments and they have a lot of responsibilities, and so it can be difficult to get everyone together at the same time. I think language and literacy barriers are something that we found across contexts, as well as the engagement of fathers. Poverty, definitely more so in Uganda, being a big barrier. And then also the power dynamics and hierarchy within the healthcare system. I think also a bit more in Uganda, but still definitely something to think about here as well. In terms of successes, I think the programs are more meaningful for those who it is meant for. So if the caregivers are involved, it's going to be more meaningful for them in the end. And we've also come up with feasible and acceptable programs. And you can just see how much Baby Ubuntu has grown and developed across the world as well. Um, and people feel a sense of ownership over the program. So for example, in Encompass, you've seen how Keely and Alia have taken the program on beyond the study that we did. But that's definitely, I think, a value of Baby Ubuntu is that people feel a sense of ownership over the program and they're allowed to sort of adapt and work together with people with lived experience to adapt it for their context. And then you do feel a sense of ownership over it. And I think that does result in it being more successful. It's also been an opportunity to learn to work more flexibly and collaboratively with all different types of people. Um, and this was a comment from Rachel in Uganda that early involvement of healthcare providers enhances program impact and challenges stigma. But I think that's important here in the UK as well, is thinking beyond research studies into wider implementation, involving healthcare providers early, I think is very important. Before I go on, Rachel, I want to know if you wanted to add to any of those points.
I think you've presented a really excellent summary on the challenges both of the co-creation but also of the programs. But yeah, I think when you were talking about the training and we also do the same training in terms of getting healthcare workers and expert parents in the room from day one. And I think we've had a lot of challenges around the power dynamics, and that's where this comment about the early involvement of healthcare providers and really explaining and getting them to understand the importance of changing dynamics and creating equal partnerships. I think when we first looked at introducing the program in Rwanda, I think it took us about 2 months of negotiation for the social workers to agree to be trained alongside the parents because they didn't want to be seen to not know in front of them. They didn't want to learn something new in front of them. And I think by the end of the week, everybody was totally transformed by the learning that they'd had and the change of dynamics. But I think that early involvement and early buy-in about all aspects of the program is really, really key to success.
Thank you, Rachel. And I think that brings us to the end of the presentation. And I love all of these pictures.
Yeah.
Children all over the world. And just a huge thank you for having us. And I think I might hand over to Michelle. Is that correct now?
Yeah, let me just echo the thanks that has been coming through the chat, especially to Alia and Keely. I know it can be really challenging to enter sort of an academic space from a place of lived experience and to share your insights and your children so generously with us. So huge thanks for doing that. It was such a powerful part of today's presentation. Kirsten, maybe if you want to stop screen sharing, just so we can all see each other a little bit better. I will begin with the questions that have been coming up in the chat, and then we'll still have space for people to either raise a hand and ask verbally or add questions to the chat as we go. I'm going to do them in order just to try and help keep myself a little bit organized. So, Sinad, I think you entered the first question, which was about the addition to the Encompass program of the getting ready for school component and what school might look like in the UK for children with disabilities versus Uganda at the ages you're seeing these kids. Can you provide a little more context around that?
I'm sorry, I was just trying to find the question actually. I wonder if I could ask Ali or Keely to briefly tell us about schooling in the UK, and then maybe we can go to Rachel or Carol, who can give us a brief overview of Uganda.
Sorry, what was the question, Kirsty?
I can read out the question. I just put it in the chat. So I noticed that Encompass had an addition to the modules of preparing families to go to school for children with disabilities. I was wondering how special needs education looks like in the UK and Uganda and how it compares and what that looks like preparing to go to school.
Or when they're early stage before they start the process?
Yeah, because it was the age group was 0 to 6, or is that correct? Yeah,
Yes,
so
yeah.
here
So yeah, we have nursery, and then reception, and then goes to year 1. If you're talking about the in the UK, we have educational healthcare plan for children. So that's another process. A parent has to request for educational healthcare plan that would go to the local authority. I think that's probably be like 6 weeks or something. Sorry, I'm not about the whole process. And yeah, so the professional will come and do assessment, and they put it in all in an educational healthcare plan before the child goes to school. So it has like what child needs, that physio input, OT input, speech and language, consultant might be involved. Yeah, that's my input. Well, I'm just saying from my lived experience with my child, that's what happened. But then again, my daughter, who has a very complex background, medical background, so with her, she needed a lot of input. She needed a lot of medical input from a lot of professionals, and a lot of support had to be put in place. With my child, I put her in a mainstream school first because I wanted her to, no one's normal. I'm not going to use the word, it's a typical child. And unfortunately, she was there for nursery and reception. I think that was up to 4 years old. But then because of her seizures, the school wasn't equipped to manage that. So she had to go into a special school, which just take in London, in East London, and where that school, they do have nurses on site, and they have teachers. TAs are trained to manage children with all different medical background. And yeah, so she's closely monitored by nurses because of her seizures. But I hope that helped. So,
that helped a lot. So it sounds like, oh, sorry, Keely, if you
No, I
want
was just going to say there's sort of like there's two sort of different types of schools that children can go to. You either have mainstream school or you do have the special needs school. As Ali was saying, Khadija started in a mainstream and then went to a special needs school. Jack has stayed in mainstream school through like primary school from like 3 up until I think it was 11, 10, 11, and then again secondary school for the later stages. So he stayed in a mainstream school and everything was adapted for him. Not sort of a smooth run, but a lot of things had to be changed and implemented for it to run smoothly there.
that helps a lot. Thank you. It sounds like it's kind of the decision of the family whether to, along with the advice from professionals through all that consultation of whether to keep them in that main school, or have them get more specialized supports in a different school. Thank you so much for clarifying.
Rachel, I don't know if you want to briefly speak about school in Uganda.
Yeah, so for the baby Ubuntu children, the because they're 0 to 3, they're younger. We wanted to start the conversation. In the community module, we start a conversation about, can your child go to school? What does that look like? Because a lot of the families, the belief that they have is that their child is not going to be able to access school. So our approach is it's sort of embedded in our community module and getting parents thinking that it's a possibility as a starting point. There are special needs schools within Uganda. They are few and far between. They're sort of the town I live in, there's 3 special needs school, and it's a huge district. So unless you're close to one of those, you would have to access a normal school. which have lots of barriers in terms of the buildings, the environments, the toilets. Access to wheelchairs is difficult, and a lot of parents and teachers, there's a lot of stigma around disability. So I think parents have to work very hard to support their children to attend school. Um, yeah, and primary school is free, but the nursery school level, the 3 to 6 year old, is all private costs. So again, is a barrier. There are a lot of really great organisations who are trying to really improve sort of knowledge about around inclusive education, and support teachers with the skills to be able to include more children. But at the moment, there's quite a lot of barriers. I think 9% of children with disabilities go to school in Uganda. I know one of our attendees can probably quote better statistics. And so Fiona, if you want to put it in the chat, what the statistic is, but I think it's about 9%, so it's really, really low. Yeah.
Thank you, Rachel. Yeah, it sounds very different from what was described in the UK. And I'm just wondering if there's a similar sort of health plan, like what Aaliyah had described, something that parents can apply for. Okay, not at all. Thank you so much.
I think
Maybe
Baby
before-
Ubuntu was largely set up because, again, even access to therapy is very limited. And I think, 15 to 20% of children in Uganda will access physiotherapy. So Baby Ubuntu, there we are, Fiona's put it in the chat now, 9% of children attend primary school, with 1% with disabilities moving on to secondary. But, also access to therapy, the statistics for that are also below 20%. 18% of children access therapists. So Baby Ubuntu was sort of developed as a starting point so parents can start to understand disability and have some techniques that they can use at home.
Really helpful context. Thank you both. It probably relates quite nicely to Sally's question, which I've reposted in the chat just because it can be hard to find when scrolling. Sally, I don't know if you wanted to speak to that question.
Hello. It was brilliant. Thank you. It's so good really exciting to hear how successful it's been and then hear it adapted to the UK, which is where I am. I found it really interesting to think about the fact that UK parents were actually, I work as a speech and language therapist. I know parents are really, really busy because they've got lots of appointments and things to juggle. And that was quite, but that's quite different to Uganda, so that there were some families who just couldn't think about going to a group because they were too busy. And I wondered if they were 0 to 6, how much previous sort of health input or physio or OT or speech therapy had parents and children had already. Is that why you combined some things? Because you thought, oh, they'll know that a bit? Or did you have to change what you had in your manual because you found out parents did know? Like Kirsten talked at the beginning about not having health knowledge or health literacy, but I wondered if you found maybe parents with slightly older kids had more knowledge in how you coped with adapting for that. Okay, I wrote it better than I said it.
No, no,
Sorry.
no. I'm happy to answer that one, Sally. And it's a great question because I was a little bit worried that when we were looking at the content, I thought parents are going to know this because if they've got a child who's 5 or 6 years old, they might have had a few years of therapy input already. But what we found is that we had parents of different ages. So some parents had a child maybe 1 or 2 years old, and then some had a child maybe 5 or 6 years old. And even though they might have known it, the parents with the older children, they like to share their knowledge. So actually that was helpful in itself, I think. If we were and that's exactly right why we combined some of the modules around maybe positioning and learning to move, as we did think that they would be getting a lot of that from their physios or from their OTs already. But when we did come to a topic where we were discussing maybe about positioning, for example, of a child, some of the parents with older children did enjoy sharing their experience. And I think there is something about social support, the reciprocity of social support. So receiving, but also giving it is as important. And I think that is the power of the group as well, being able to sort of give your experience and also receive other experiences and learn from each other.
Thank you. So those parents were almost like mini, not that's not a word, mini expert parents, not as expert as
Yeah.
Ali and Keely, but able to share their knowledge. Yeah.
Exactly.
Thank you. And Hannah, I see your new question in the chat. I don't know if you wanted to ask it out loud or if you'd like me just to summarize for it. Oh, thank you so much, Keely. I see that you have to hop off. Really appreciated having you here. Go ahead, Hannah.
Yeah, it might be too early of a question. This program is so great. We're doing similar things here in Montreal where we're trying to address a gap in services while families are waiting for diagnosis or developmental programs. Because it can be 1 to 2 years at a very vulnerable age for children around 18 months to 3.5 years old. So we're at a stage for our project where we're thinking about implementation. And so I was curious, again, I know it's quite early in your process, but do you have a vision for implementation and, how families will access this program in the future?
Just to check, you talking about the UK?
Yes.
Yeah. This is the million-dollar question about implementation, because you do a lovely study and you sort of think, oh, this is feasible and acceptable, but then actually what will this look like in reality? Particularly, who will own the program? Will it be through a government-funded healthcare system? So that's been really successful in Rwanda. Rachel spoke briefly about that, where the Baby Ubuntu program has worked closely with the government-funded healthcare system. Or will it be more charity owned or by local authorities? And so I did do, as part of my study, I did interview some key partners in all of those areas to talk about what implementation might look like and who could potentially own something like this. But that is all very much in process, and that is definitely the next stage to think about implementation. So I don't have anything concrete to tell you yet, but I understand that these are the difficulties.
Just maybe one follow-up, Rachel. I was so intrigued when we first met about the growth and spread of Baby Ubuntu in your context. And as we think forward to implementation questions, like how did you do that? Big question.
Yeah, so we've gone, as Kirsten said, we've grown a lot recently in the last 3 years. So we've gone from having 8 partners in 3 countries to having 27 implementation partners across 13 countries. So it's been a lot of learning very quickly. A part of it, I think, for us has been about capacity building. So in response to that, we've developed the master training, came on board as we started to grow. We've also created an online version of the 5-day facilitators training to support growth. And also having a team available who can support either within our core team, but are also our master trainers who can support organizations within the same country in terms of mentorship to support fidelity. So yeah, there's been lots of learning around that scale up. And as I said, the shared learning I think is really important. So getting, partners from those 13 different countries to share their experience, like Kirsten did, about, the differences and the similarities between the UK and Uganda, and what worked in Kenya, would that work in India? And discussing that, I think, is a really key part as we grow and learn about implementation going forward.
Yeah, thank you. Maya?
Yeah, thanks so much for such a wonderful presentation. I had a quick question, which was you had mentioned kind of the value of the icebreakers kind of in bringing everybody together. I know this is maybe a silly question, but I'm curious how you went about kind of breaking the ice and what ways you started off your sessions to build those relationships and start things off on the right foot as I think about icebreakers for my own co-design work. For, I guess, both programs, Encompass and Baby Ubuntu.
This is a great question because I went to the master training in Uganda and saw some of the icebreakers that you did there, and I'll let Rachel and Carol speak about that in a moment. But it was very different to what I think people would do in the UK. So icebreakers was an interesting one, and it's not a silly question because I do think it needs to be culturally relevant to be able to get people to feel comfortable, but also break the ice as well. Um, Rachel, do you want to give, or Carol, do you want to give a few examples of the ones you do in Uganda?
If Carol's still able to unmute. We do sort of introductions, ball games. We do one of my favorites is where we stand in a circle and we pass a ball of string around and create a web network. The one for the feeding module is around working in pairs and one caregiver getting themselves into an awkward position and the other caregiver trying to give that person a glass of water to help them understand what it's like to be fed and in a bad position. So sometimes we try and get them relevant to the module. Sometimes they're songs. Yeah, Kirsten, what else? I don't know what else you've added for Encompass, but it's just something generally everybody ends up laughing and giggling about sort of the process and yeah, starts you off in a good mood. Yeah.
I remember bringing some of those, and I remember Alia clearly saying, I don't think we can get people to feed each other. I don't think that's going to work here. And also some of the songs, I think. So we had to change some of those. But the icebreaker that everyone loved the most was when the facilitator drew a picture of a big wall and they told a story about how you're walking along a path and you come across this big brick wall. And you know you're going to, at the end of the story, you will get to the other side, but you don't really know what the middle is, and you don't know how you're going to get past this wall, how past this barrier. And then everyone chips in with the most ridiculous things they can think about how to get over the wall, round the wall, get a helicopter over, or chip at it with a hammer. So things like that is what we did.
Awesome. Thanks so much for sharing.
I think I've covered the questions that were. Oh, no. There's a new question that I missed from Zeng. Would you like to share that?
Yes, thank you. And thanks again for all the presentations. I was wondering, sorry, I came a bit late, but I was wondering how the co-design, like the process and the workshops, and hearing you talking about the icebreakers, how that was developed, if that was like based on something or something that you self-developed. It sounds fantastic. Yeah.
I don't know if Rachel, you want to speak about a specific framework. In terms of the adaptation, we use the ADAPT framework to talk about for the actual adaptation process. But Rachel, was there a framework for the co-design for Baby Ubuntu?
No, we didn't really. I think it's now with your work that we've got a much clearer idea of a framework. We sort of use fast track, sort of an iterative cycle of learning. So we ran a group and got 360 feedback from the parents and the facilitators, and then edited the content accordingly. And we went round that cycle 5 times. So we sort of, reflected and learned, and it was quite a fluid and natural process without sort of a specific framework. And I think Kirsten's done a beautiful job of giving us a really solid framework to work on when other partners come to us and say they'd like to adapt the programs. So, yeah.
Yes. Thank you. Yeah.
I'm submitting I think today I'm hoping to submit. I have written up the actual framework and how we did the adaptation. So that will hopefully be published in the near future.
Amazing. Cool. Thanks both. Thank you.
Maybe I'm allowed to put in my own related question, which is when you have so many people who are adapting and modifying the program, how do you make a determination about what's needed to retain fidelity to the program versus which components are modifiable?
Yeah, so we've based it around core values. So our core values are that the participatory approach has to be maintained, that the expert parent role has to be maintained, although sometimes for new organizations, they have to run a few groups just with healthcare workers to recruit parents to be involved as expert parents. That there has to be that sort of the content has to promote inclusion, and it has to be co-designed, that any changes are not made by a set of therapists or doctors sat somewhere, that they're made in consultation and designed with caregivers. So those are our sort of core values that we ask, if you're adapting, you stick with. Yeah.
Thank you. Jillian?
Yeah, it was not a question. I just want to react to that because I'm in the middle of writing up a piece right now where it's a case study of co-production of 3 programs that have kind of gone around the world. And how did it emerge and how did it happen? And that value-based piece is core to all of them. You can pretty much do what you want as long as you're true to those principles and adapting to your context. So I just think this is really, really helpful work that you've done that's going to expand on all of that. And really interested to see, because we're sort of saying in a co-design or co-production context, it's a little bit different than a typical program that you adopt and you do some adaptation to, but it's actually the entire process that's being and the value system that's being taken from one place to another. And I think that's just so important. So just a reaction.
I'll just comment that there's been lots of requests for any related publications or resources, and Leah, when the podcast is ready for sharing. So maybe what we can try to do is combine those into a PDF and attach them in the comments of the video. I have no idea how technology works, but we'll try to make those available all together if you send us your citations as things become available. Kristen, there's some excitement for your new article coming out as well, so we'll cross fingers for your submission. Were there any other questions, comments that people had? Yeah, Maya?
I'm allowed to ask another brief one just because I'm appreciative of everyone's expertise here. Looking at kind of the challenges piece, when you had mentioned that there were all different ways people like to participate. Some people wanted to edit the written materials, other people just wanted to say their piece. I'm imagining some people wanted to put in more time or less. I'm wondering if you used a specific process or I guess how you navigated that and how you approached discussing what those options were with the people involved in the co-design.
Thank you for that question. I think I did look at the involvement matrix, which was developed. I think it's for families of children. I think it's for families, looking at what sort of roles they could play in the co-design process. And I did sort of bring it to the group, asking, if people want to be more advisors, more partners, what they would like to do. Oh, there we go. Thank you for putting it in the chat. But in terms of the actual process of how people gave input, I just asked what they would like to do. And I knew Rachel's gone off camera now, but I knew she told me that some of her expert parents involved in co-design used to send voice notes, I think. They would read them. Am I right, Rachel? They would read your updated chapter of the manual and they would just voice note you their ideas. And I think just hearing that helped me to know there are so many different ways to get feedback. So yeah, I definitely had one parent on my group who liked to read and type comments for me, and then others who were just happy to verbally share ideas as well. I don't know if that fully answers your question, sorry.
And that was really helpful. Thank you.
Yeah. This is such a rich discussion and such an engaging discussion. We're so thankful to draw from all of your expertise. It's incredible what you've been able to do with growing this program and adapting this program in so many different contexts. So thank you again so much, especially Elia, and to the teams for presenting today. I will get us back to business. And thank you, Sinette, for sharing. We do host these sessions quite regularly, a combination of members of our team sharing some of what's going on in our programs of work, and also with invited guest speakers from around the world. Sometimes we have trainee presentations, which are always very exciting. So if you're interested in hearing more about what we have going on and joining these sessions, you're welcome to join our newsletter, and that way you would just get any upcoming sessions directly to your email box. So please feel free to add yourself to our list. And so now we have one more. It is always helpful to get people's feedback on these sessions so that we can tailor the material and the format to the needs of our growing community. So if you would like to provide any feedback, either for us as the host of these sessions or to the team, I'm happy to compile and pass it along to our presenters. And like I said, we will be posting as soon as it's ready the recorded video up on our website, and we'll try to add to that publications and links and related work as soon as that's available to us. Otherwise, thank you very much. I'll hang on the line for an extra couple of minutes, and people are welcome to if you want to kind of mill about the room like we used to in the days of in person. But otherwise, I'm very grateful for our presenters' time and everybody for joining.